Dr. Narendra Bagri sir to present the next model construct.
Good morning all. With permission of the esteemed judges, on behalf of our study group, I would like to present our study on the spectrum and outcome of children with DADA2 common experience of India. So, given coming to the background and rationale of the study, we understand that the DADA2 is a monogenic disorder which has a close resemblance with polyarteritis nodosa, and there are series where approximately 1/4 of the children with PAN are actually harboring this particular mutation. They have a wide spectrum of presentation, including central nervous system involvement, which is the striking feature of this particular entity. Apart from that, the other clinical manifestations could be pure red cell aplasia, pancreatitis, pulmonary hemorrhage, or immunodeficiency of variable degree. So the problem statement is that these kids will often present a wide spectrum of physicians with different subspecialties, and there is a need of probably educating or increasing awareness about this particular disorder. So with this thing, and there is a point of differentiating DADA2 from PAN because of therapeutic implications. And thus, the aim of the study was to describe the spectrum and outcome of children with DADA2. So that this is a retrospective multicenteric study where each study was a coordinating center and other partner centers are listed below. We conducted this study for the patients who have DADA2 mutation from January 2014 to July 2023, and the inclusion criteria were patients with DADA2 confirmed mutation were enrolled for this study, and the pre-designed performa, the key clinical features, the age of presentation, the investigations, laboratory investigations, and the NGS results and the imaging findings were recorded, as well as the treatment and the outcome of the children. The next generation sequencing was performed to ascertain the mutation in ADA2 gene, and the variants were classified as per AGMC classification guidelines. The data analysis was the de-identified data from the centers which consented for to be part of the study was taken in web-based Excel sheet, and the coordinator center screened the data for the correctness and any accuracy or incompleteness, and corrected with the participating center for any discrepancy. The clean data set was analyzed using Stata 14. The study was approved by the Ethics Committee, and since it was a retrospective study with investigators initiated when there was no funding involved in the study. So coming to the results of this study, we enrolled 16 children, 11 females who had a confirmed DADA2 in this study. The mean age of boys of 47 months and the girls of 50 months. And the age of presentation is quite variable, ranging from 3 months to 144 months, with the diagnostic delay ranging from again very range 2 months to 90 months. The diagnosis was confirmed in clinical exam in all patients except one. That this patient was a sibling of a child who had similar manifestations and a confirmed mutation. So the most common clinical feature of fever and rash, counting around 70% of the patients, and half of the children had classic characteristic feature of CNS stroke, presenting with neurological manifestations, weakness of the nerve calcium, hypertension, arthritis, or other manifestations. The other important things were hepatosplenomegaly, Raynaud's phenomenon, they agree. The bone marrow failure syndrome was observed in 2 patients, and interesting to note that one of these patients had developed features of vasculitis down the line when she was 10 years of age. And this is the classic rash that we observe in these patients, that livedoid or receive kind of rash along with lacunar infarcts. And here is the ball wall edema suggesting GI involvement, and here is the aortic and aneurysm, thrombosis, and the infarct in the artery. And here this image shows the digital substructure angiography with microaneurysms consistent with PAN or DADA2. So the exome sequencing was done in all patients, as I told, except the one child who was a sibling of a patient, and the 13 patients were homozygous and 2 were compound heterozygous for this, and they all had shown the pathogenicity in silico tool prediction models. And interestingly, we also observed an previously unreported variant in the girl who presented initially with bone marrow failure syndrome, but later on developed vasculitic features. This was not reported previously. Coming to the follow-up and outcome of these patients, as we can see that these patients were treated with host of immunomodulatory therapy prior to the definitive diagnosis, but once the definitive diagnosis was made, they were given anti-TNF agents and did well. One of the patients with bone marrow failure syndrome underwent hematopoietic stem cell transplant, however, could not be survived. So at the last follow-up, all patients were off steroids. There was no recurrence of CNS stroke, that is important to note, no serious adverse event, and 2 patients succumbed to the illness, and both are having bone marrow failure syndrome. There were limitations of a study, including short follow-up period, and the family screening was not performed. So to conclude, the symptoms were variable and they were presented at a wide range of age, and it's important that they had a characteristic CNS manifestations which is not as common in classic PAN, and children with vasculitic phenotype respond well to anti-TNF agents, as we have seen in our study, and we could taper the steroids in all patients. Bone marrow failure syndrome typically presents as DADA2 as an early age of onset, but one of our patient has a vasculitic phenotype down the line, so maybe these patients, if followed for a longer time, might develop vasculitic features, and targeted sequencing using this is often sufficient for the diagnosis. Thank you so much, and I would like to acknowledge the participating centers and my colleagues who have supported me in this study, and I'm happy to share that the paper has been accepted for publication as well. Thank you so much.
What did you tell the participating centers when to suspect DADA2 deficiency? Because majority of the children had only fever and rash. What was the clue? Was it the stroke, the clue?
It was the stroke, as 50% of the patient.
The stroke was there in only half.
In half, but actually the inclusion criteria involved the patients who have already been diagnosed as DADA2 in those centers. So it was not a cross-section study where we tested for the mutation.
So if you were to advise me when to suspect DADA2 in the children, what would you say? I
would say that yes, any patient with clinical features of polyarteritis nodosa along with CNS manifestations, which is typically less than 5% classic PAN.
What features of polyarteritis nodosa?
For example, the classic rash, the livedoid racemosa, racileticular pattern of the rash that we have found in most of the patients, along with persistent fever, neutrophilic leukocytosis.
I'm not clear what rash
the rash is
with polyarteritis nodosa have.
The typical rash that we found was a racemosa kind of livedoid racemosa kind of rash in these patients, in addition to gangrene and other features.
Actually, the polyarteritis nodosa features are like sudden onset blindness. You have GI emergencies like hemorrhagic perforation of the gut and hypertensive crisis, perinephric hematomas. These are the types that I have seen. We have 12 patients whom we are looking after, and many of these we've actually diagnosed retrospectively. Question is, did you do ADA2 analysis in some whom you suspected it but did not get a positive?
This is a valid point, sir. I think this is a limitation of the study. We didn't look into the enzyme assay of these patients. But yes, you are right. In certain patients where there is intronic mutations, that levels might help in ascertaining the diagnosis.
So I just wanted to ask that the common mutation which we always see, C139G2A, so did all of your patients have that common mutation in the exon 2?
Yes, there is only the most common mutation was already reported, and one patient who presented with bone marrow failure syndrome had an unidentified variant in that.
So that was a compound heterozygous.
Yes.
So only the one gene. So
yes.
What we have done in our institute is screen, because it's a founder mutation seen in India, you can just sequence exon 2. It's a small exon which you can sequence, and you can pick up most of your cases. When to suspect? Every child who comes to you looking like PAN should get a ADA2 mutation done, because you would pick it up almost in 70%. And most of us would have 10 to 15 patients, each of us. So if you're going to make a PAN-India study, I feel it should be with all centers rather than calling 3 centers as Indian study. Because there are many, many centers who have large number of patients with them. So it will be good idea to collaborate with others.
Thank you so much. And I think you are right that the spectrum is vast. The bone marrow failure syndrome is again patients who would present with this.
It's been found that the gene is present in 1 in 256 individuals, and therefore it is expected that this would perhaps be the commonest hereditary autoinflammatory disorder in India, notably in the Agarwal endogamous community.
Thank you, sir.
Thank you.
you, ma'am. I request Dr. Paromita Nath to present her paper.
Good morning, everyone. I'm Dr. Paromita Nath. Today I'll be presenting the identifying predictors of IgA nephritis in pediatric IgA vasculitis, a retrospective analysis from our center. So I'll be discussing the study in the following headings. So we know IgA vasculitis is the most common vasculitis in children. It results due to IgA deposition in the small vessels and leads to multi-system involvement like skin involvement or arthritis in the form of musculoskeletal involvement, GI involvement, or even renal involvement. And among them, renal involvement, that is IgA nephritis, it can lead to serious complications. So in this background, we tried to find out the predictors in those presenting with IgA vasculitis. So the objectives of my study was to compare IgA vasculitis with those having IgA nephritis and also to analyze the data set for identifying the predictors of nephritis with IgA vasculitis. So it was a retrospective study done on 83 children diagnosed with IgA vasculitis in Manipal hospitals from 2011 till 2024, and the comparative analysis was done among patients with and without renal involvement. So coming straight to results, total 83 patients were included in this study. The age range was from 2 years till 18 years with a median age of 7.1 years and interquartile range of 5 to 10 years. And there was no sex predilection as there were 43 males and 40 females with a ratio of 1.02:1. So the most common involvement was cutaneous, we can see, followed by musculoskeletal involvement, which was 59%. 48% had a GI involvement, and renal involvement was seen in 26.8% patients, that was 22 patients. So coming to the renal involvement, all of them had proteinuria, whereas only 14 patients, that was 63% of them, had hematuria also. So in the proteinuria subset, we can see most of them presented with nephrotic range proteinuria, that was 14 patients, followed by non-nephrotic range, that was seen in 5 patients, and trace albuminuria was seen in 13% patients. So coming to the predictors, if we can see that, so as we can see, if we compare the IgA nephritis with those without renal involvement, that was 16 patients, the age of onset was comparatively higher in those having IgA nephritis, that was 9.8 with a standard deviation of 3 years and a significant p-value. Male-female ratio, there was not much predilection, although those having hypertension at disease onset, they tend to develop IgA nephritis subsequently. Arthritis or arthralgia or GI involvement had not much significant p-value, but we dig deep into the GI involvement and we found out that those having severe GI involvement in the form of intersusception or hematochezia, 53.8% of them developed IgA nephritis subsequently, whereas those having mild GI involvement, only 25% of them developed later on, whereas with those without any GI involvement, only 18% of the cohort developed IgA nephritis subsequently, and the p-value was significant in this group. And the lab investigations were not showing much of a difference, so I have included only the important finding which I got from my study, that was neutrophil lymphocyte ratio. So the median value was 3.35 in those having nephritis as compared to those without nephritis, which was statistically significant. So to conclude, the predictors for development of nephritis in IgA vasculitis, which was found in our study, was older age at onset, those having severe GI involvement in terms of hematochezia or intersusception, and also those having a higher neutrophil lymphocyte ratio more than the baseline value. And the limitations of our study was it was a retrospective study, and also the sample size was pretty small. Thank you.
Where is the prediction analysis? Your title said something prediction. You have simply compared two groups of IgA nephritis versus the IgA vasculitis, as you are saying.
Sir,
what is prediction about it?
Sir, I have compared those who have developed nephritis subsequently with those who did not develop nephritis later on. Because most of them without nephritis, and
we don't usually use the term prediction for that. How did you define nephritis? How did you define nephritis or categorize the patients as nephritis?
Sir, those who develop proteinuria or hematuria later on.
Either hematuria or hematuria and proteinuria.
Proteinuria, yes.
They didn't do a biopsy in them.
Sir, only those who had a persistent proteinuria or unexplained hypertension, persistent hypertension with oliguria or heavy proteinuria, only for them we underwent a biopsy.
It's a nice data set, but you can reanalyze it. Because did you take all patients who had no nephritis at onset?
Yes.
So what was the lag period in development of nephritis? After how much time did they develop nephritis?
Ma'am,
so that you have to tell us.
That was
because if it came after 5 days, that could be that we didn't do the test or that there was a fallacy with the test. That we don't take. Generally, hypertension is itself a feature of nephritis. So taking that as a predictor would be a fallacy. And then you need to do a multivariable analysis. Because age and GI involvement is always related. We know that. Older individuals have more GI involvement. So unless you do a multivariable analysis, you won't be able to know which is the true predictor of nephritis to happen later. So you can reanalyze your data. Thank you. So we have any other questions from audience? We have some 30 seconds. Any burning questions? What did anybody have elevated creatinine or a lower GFR?
Ma'am, those having high creatinine and low GFR, we did a renal biopsy. I have not mentioned them. That was a limitation.
Thank you.
Thank you.
Thank you, ma'am. Thank you, sir. Thank you, Paromita. I request Dr. Anand Sasidharan to kindly present his paper.
Good morning. At the outset, I would like to thank the NCPR team for giving me this opportunity to present the series of 3 cases of infantile Takayasu arteritis. So going to the case number 1. So case number 1 is a child who presented in 2023. At the time, she was 2 months old with fever, persistently elevated inflammatory markers and thrombocytosis. She was evaluated in an outside hospital where they did a 2D echo, dilatation of the right coronary artery was seen. COVID antibodies were done even though the COVID pandemic was over by that time, and they treated her as miss with IVIG 2 gram per kg. However, in view of persistently elevated inflammatory markers, she was referred to us at the age of 3.5 months. So coming to the course in our hospital, on examination there was no pulse asymmetry. BP was above 95th centile in all the 4 limbs, and there were no external features of Kawasaki disease. The lab parameters showed the elevated WBC count, platelets was 13 lakh, CRP was 80. 2D echo done showed a giant aneurysm with a Z-score of 12.75 in the left LAD and a large aneurysm with a Z-score of 5.76 in the right coronary artery. So in clinical features which is atypical for KD or MISC, and in the presence of systemic hypertension, we suspected the child to have a large vessel vasculitis, and she underwent a CT aortogram which showed focal dilatation and irregularity of the left anterior descending artery, a dilated origin of the right coronary artery, and focal narrowing of the renal artery. So we made the diagnosis of infantile Takayasu arteritis in this kit, and we initiated her on statin injection infliximab. Infliximab, actually we gave 3 doses. After the 3rd dose, she developed a severe anaphylactic reaction. Steroids, anticoagulation and antiplatelets in view of this giant aneurysms, antihypertensives, and MMF also was given. Now the child is follow with us around 20 months, and she is doing extremely well with the reduction in the size of the giant aneurysm, with a C-score reduction to 3.06 and the C-score of the right RCA reduced to 0.25. Now coming to the case 2. Case 2 was another child in 2022. She presented at the age of 5 months with high-grade fever, irritability. She was initially treated as UTI in an outside hospital, however persisted to be symptomatic. So at the age of 7 months, they did an echo which showed dilated coronaries. Again, they did a COVID antibodies which was positive, even though the COVID pandemic was over by that time. Treated as MISC with IVIG 1 gram per kg for 2 days, followed by oral steroids. However, on tapering and stopping the steroids at the time of 9 months, she again developed symptoms in the form of anemia, elevated inflammatory markers. 2D echo showed a worsening of the coronary dilatation. So at that time, they suspected her to have an atypical KD, and they again gave a pulse steroids followed by oral prednisolone at a dose of 2 mg per kg per day, and they referred to us. And all these admissions, she also had severe anemia requiring multiple blood transfusion. So in our hospital, on general physical examination, she was found to have absent radial pulses on the both sides. She also had elevated blood pressure with discrepancy in both the upper and lower limb BP. Hemoglobin was 8.6, platelets was 481,000, ESR was 109, CRP was 113. There was persistent coronary dilatation when we repeated the echo. CT aortogram showed stenosis of the bilateral subclavian and mural thickening of the descending thoracic and the abdominal aorta. So treatment, we initiated her on IV methylprednisolone followed by oral steroids, MMF, tocilizumab of total of 10 doses was given, along with antihypertensives and antiplatelet. She showed excellent clinical recovery with resolution of fever spikes, downstream inflammatory markers, and repeat CT aortogram done after 1 year shows there is more thickening of the aorta, and she is now doing extremely well. Coming to the last case, this is a Maldivian kid who her index presentation was way back in 2020. At the 6 months of age, she presented with fever, weight loss, and severe anemia requiring multiple blood transfusion. The initial lab investigation showed very high inflammatory markers, microcytic hypochromic anemia. The rheumatology referral was given to us in view of, so from the history, there was past history of superficial thrombophlebitis and history of palpable skin nodules, and on clinical examination, there was high BP. So with this, considering the age, elevated BP, past history of skin nodules, we consider the possibility of a medium vessel vasculitis span. So we did a CT aortogram which showed focal outpouching in the anterior wall of the aorta. There was multiple vascular aneurysm over the neck vessels, and there was a mild wall thickening involving the aorta and its branches. So we commenced her on anti-TNF therapy, etanercept, for around 6 months. However, she got clinically improved, but again, she stopped all medications. The next presentation was with high-grade fever in 2023, elevated BP and high inflammatory markers. CT aortogram done, this time showed diffuse luminal narrowing of the descending aorta, along with focal narrowing at the origin of the left common carotid. The aneurysm of the vessel resolved. Now, we made the diagnosis of the Takayasu in her. We treated with IV methylpred, subcutaneous tocilizumab, and MMF. Now, the child is doing extremely well, and with resolution of the fever and the inflammatory markers. So, to conclude, infantile Takayasu arteritis is a rare disease. Takayasu arteritis need to be considered in any infant presenting with PO and persistent inflammation, even without the classical features of absent pulses and BP disparity. One of the close mimic of Takayasu is Kawasaki disease. Even in the absence of treatment, the fever in Kawasaki is usually self-limited and rarely extends beyond 3 to 4 weeks. Differentiating both conditions is extremely important, as we know the IVIG doesn't have any role in the treatment of Takayasu arteritis. And last, the MISC is non-existent now and shouldn't be misinterpreted in children presenting with persistent fever and raised inflammatory markers. Thank you.
So just linking this with one of the previous communications on DADA 2, somewhere I got a little smell that we could be dealing with a monogenic vasculitis. Now, at this age group, especially with anemia, multiple transfusions, I would definitely request you to please, and especially with the recurrence, to consider a monogenic vasculitis.
ADA2 levels were done for everyone, sir. It was negative. ADA2 levels, yes. Genetic study was also negative in all the three, yes.
As an extended manifestation of Blau syndrome, okay, you can have Takayasu arteritis. That's another important thing. And the third point I wanted to make, when you say coronary aneurysms, you just have to think, I'm not saying in this case of yours, that are coronary aneurysms more common in Takayasu, or is Takayasu more common in Kawasaki? Meaning aortic involvement in Kawasaki versus coronary involvement in Takayasu. This is a flipped situation. And I would just say that this is a Takayasu-like phenotype, but not label it straight away as Takayasu arteritis.
So, I have not seen much of infantile Takayasus. We see the other ones. So, do the aneurysm regress in all the patients? It's very unusual to see in kids or adults aneurysms to ever regress in a person who presents with Takayasu's arteritis. Aneurysms are also uncommon in Takayasu. This is only one of the complications. So, in all the three kids, you have shown complete regression of aneurysms. That's a very surprising finding.
Size has reduced, ma'am.
No, size has tremendously reduced from 15 to 3. Z-score. It's a tremendous decrease. In the third one you said is totally disappeared. These are very, very unusual findings for Takayasu. It may be a totally different disease, infantile TA, and I'm not aware of it, so I am a naive person in that area.
Well, I'm also surprised that you call them Takayasu. Of course, there is many things to be learned every day in life, but the way you are saying, I've never seen Takayasu or understood Takayasu that way. A young infant presenting with high inflammatory markers, ESR 108, TLC count 38,000. That's not the granulomatous vasculitis of the aorta would present. They have elevated ESR, but they don't have TLC count 38,000. That is your first case. Second case, you had some vascular abnormality, some venous abnormality, and coronary artery disease can be involved in Takayasu, no doubt. And Takayasu involvement causes stenosis and coronary artery aneurysms. But usually in adult cases, what we find is a stenosis of the coronary artery, a dilatation of the coronary artery without the main branch aorta and its main branches involved. To label is Takayasu, you have gone beyond my expectation.
Just to have a thought, that it may be some different disease, that's what we're saying. But an excellent cases. Thank you, Anand. Thank you.
Definitely thought-provoking without a doubt. An interesting phenotype.
Absolutely. Maybe new disease.
Thank you to all our participants and our esteemed judges.